I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about something that is poorly understood and overly tested, which is prolactin levels. So what is prolactin? It is actually a hormone that's produced by the anterior pituitary, primarily relating to pregnancy and breast milk production. Actually, we can actually live without prolactin, which is kind of interesting because it wreaks a lot of havoc on the fertility system. But when it's out of balance, like when there's a micro or a macroadenoma, for instance, that can really affect ovulation. It can affect endometrial receptivity. And it's important to understand it can even be involved in recurrent pregnancy loss. And so, how is it regulated? Actually, prolactin is regulated by dopamine. They used to call it a dopamine inhibitory substance. And when prolactin levels are elevated, it can actually reduce GnRH pulsatile secretion, which can reduce FSH, disrupting ovulation and reducing fertility. It's actually important in both men and women, and it can affect sexual function. And if it's too high in men, it can actually cause gynecomastia as well. So interestingly, there's been some discussion on one of the fertility groups that I help to provide value in. And there was a situation recently where a male partner had really low testosterone levels and poor sperm. Lo and behold, he ended up having prolactin through the roof. And, as I think about, male evaluations as well, I always think about when there's sperm issues, always checking your prolactin because it is truly a low-hanging fruit. It is pretty easy to treat when we can find it. And I hate when there's undiagnosed things that can really affect not only people's fertility journeys, but even their fertility at home. It's really important that we understand, what can affect fertility both on the male and female sides and test and treat appropriately. Okay, so how do we test for prolactin issues, right? So say you're listening to this, maybe your cycles are irregular, or maybe you have recurrent loss. I'd say in my practice, those are really the two situations in which I really do routinely check a prolactin. Otherwise, it's not in like amenorrhea, of course, or oligomenorrhea. And those are the situations where I check because otherwise there's not too much evidence for it. But how do we check? I always say check fasting and follicular because a lot of things can affect the prolactin assay. If we've had a meal, if we've just exercised, if we've just had sexual activity, even the seatbelt rubbing across the nipple can affect prolactin levels. Even venipuncture, getting your blood drawn. Gosh, we're human pincushions at the IVF lab, right? Sometimes even venipuncture itself can affect the prolactin levels. And so, if I ever get a first one, I don't freak out. I take a deep breath. I tell my patient to, definitely make sure that they're fasting and follicular and that they've sort of followed the guidelines that I just, went over in terms of exercise and sexual activity and such for the last 24 hours. And then we check a prolactin. Now, if it is still elevated, now what is elevated? Elevated is elevated in the reference range of the lab that we're checking, but usually if it's in like the mid to high 20s, in most reference ranges, that's considered elevated. If it's elevated, then, we repeat it. And if it's elevated a second time, then we do a little bit more of an evaluation. Of course, in my history, I'm going to want to know, is somebody having headaches? Are they having galactorrhea? Are they, having any of the other issues, the sort of bitemporal hemianopsia is what we learned about in medical school, visual field testing, et cetera. But it's really important to understand like the big picture because sometimes you can actually even check a prolactin and it's normal, but somebody might actually have a macroadenoma or something because of the hook effect, which can make labs look, falsely normal when they're actually abnormal. So you got to really understand these things. So, say I get an elevated prolactin times 2, my next step is going to be a pituitary MRI. Really important to understand that we're getting pituitary cuts here and not just like a routine MRI because some of the microadenomas are like 2 or 3 millimeters and you might miss them on a regular MRI. So I always put that in the requisition. And then, if we do have a microadenoma, then we have to treat it. Certainly, if we have a macroadenoma, we have to treat that as well. But it's really important because these are things that can really affect the journey of somebody. So if we can figure these things out and recognize them, then we can get somebody on a better trajectory. I've had a number of patients actually where all I did was treat their prolactin levels, their hyperprolactinemia, and they ultimately did conceive. Or maybe it was somebody who had recurrent pregnancy loss, they had ovulatory dysfunction and luteal phase issues subsequently. And then I treated their hyperprolactinemia with cabergoline and they sustained a pregnancy. So it can be very satisfying. You know, we do have algorithms for, what happens when a person does get pregnant. We will usually stop the cabergoline if it is a microadenoma. If it's macroadenoma, we usually treat through. And there's also guidelines in terms of like how often to image people and when to consider stopping these medications as well. And so, it's not necessarily a simple topic, but like I said, it can be very rewarding. And, sometimes I think it's overtested, but sometimes it's forgotten about as well. It seems like it can also actually affect AMH levels as well. So again, thinking about who to screen people who are having oligomenorrhea or people who have symptoms of, headaches or galactorrhea, also recurrent pregnancy loss, or also male factor infertility. Those are, great people to screen. And then the good news is that there are things that we can do to help. I actually can be a little frustrating if it's just a microadenoma, it's pretty easy to treat actually. But if it's a medication that somebody needs to be on, say a psychiatric med, that needs, full multidisciplinary efforts to try and help people in that situation. But I will say, again, there's so many things in our field that we can't positively affect, but this is one of them in the appropriate setting. And like the ASRM document says, it really can make a difference in people's outcomes. So again, hopefully this was helpful and know how much I love you. Till the next time. Bye.